everybody, and welcome to this additional IJB to help us catch up with some work that was still hangover from the first wave of the pandemic, but also to give us really important updates on vaccinations, among other things. I'll just hand over to Derek to do the roll call of members and to explain about the recording. So over to you, Derek.
Good morning. Thank you very much for that, Chair. Members are reminded that this session of the IJB is indeed being recorded and will be uploaded into the public domain later this afternoon. Members may wish to consider either switching their cameras off and being on silent audio until such time as they wish to participate. I will start with a roll call and I'll begin with Councillor Duncan, who has indicated her presence. Thank you, Councillor Duncan. Luann Grugion.
Morning, Derek. Thank you.
Good morning. Thank you. Councillor Bell.
Present.
Good morning. Councillor Cook.
Good morning.
Councillor Leslie Dunbar.
Good morning.
Morning. Kim Crittenden.
Morning.
Good morning. Alan Gray has indicated he will attend the meeting at 10:30. John Tomlinson.
Yes, present.
Thank you. Sandra MacLeod.
Yes, present.
Thank you. Alex Stephen has indicated he will be slightly delayed in joining this meeting. Caroline Howarth.
Good morning.
Good morning. Chris Littlejohn has tendered his apologies in advance. Mike Adams. Morning, Mike Adams. Do we have anybody substituting for Mike at all? No. No. Jenny Gibb.
Morning, everyone.
Good morning. Jim Curry.
Yeah, morning.
Morning, Jim. Graham Simpson.
Good morning, Derek.
Good morning. Maggie Hepburn.
Morning, everyone.
Good morning. Shona McFarlane.
Good morning, everyone.
Alison Murray.
Morning.
Good morning. Howard Gemmell.
Good morning.
Good morning. I'm here as Clark. Kundai Sinclair should be attending as legal.
I am attending, but I've got a report, and John Forsyth is attending as legal today, and he's present here.
Okay, John. Good morning. Thank you for that. I think that is about the list. Wait, I'll just check. Angela Scott.
Good morning.
Good morning to you. And we have the various authors that are also present in addition to those substantive voting and non-voting members, Chair.
Okay, thank you very much. And again, good morning and welcome to everybody. We'll just crack on with the business, I think. Howard, your hand was up.
It was really just to say that I've been approached as a service user representative by a patient in the old Aberdeen practice. And I wondered whether I could, and he also copied a letter to the Ombudsman. And I just wondered whether at some point in the meeting, I could maybe have an update on where we are with that.
Of course. Would it be all right to take it as part of the Chief Officer's report? So that's
Okay.
item 8.
Yeah, whenever really.
Okay. Okay.
Okay, thank you.
Okay, thank you. And good morning, Mike. Mike Adams, we missed you on the roll call. I'm glad you're here.
My apologies for being late. Staff
No.
side before us, Sarah, so you can imagine.
Okay, you've done well to get out before lunchtime, yeah. Okay, so do we have any declarations of interest? Caroline.
Yeah, morning. As an independent GP, I'll need to declare an interest with regards to the 2C remodelling that was part of your last IJB meeting. So I would propose that I step out whilst you're approving the minutes, and if someone can let me back in, and I guess I'll be guided around Howard's just request there in terms of an update if you feel it'd be better if I stepped out as an independent GP.
Okay, that's fine. We'll make sure that Derek asks you back in after we've considered the minutes, and I think it's your decision whether to step out in the update discussion. I think if you are going to step out, just let us know so we can record it for the minutes. So.
Chair.
Yes, Sandra.
Sorry, could I make a suggestion? I wonder if I give the update during the minutes to allow, would that
course.
be, do you want me to give the update to Howard to the minutes and that'll just clear it off? Yeah.
That's a very good idea. Yes, we'll do that. Okay. Right. Thank you. I don't see any other declarations of interest. So we don't have any exempt business today. And we're now moving on to the standing items. So we've got the minutes of the board meeting of the 1st of December. I'll take them for accuracy and matters arising at the same time. So if you stick your hand up when we get to the page, if there's anything. So page 7, page 8, page 9, page 10, page 11. Leslie.
Hi, page 10, the third paragraph. I think it's just a typo. It talks about locality impairment groups.
Okay. Yeah, that's on page 11. Yes,
Sorry, but the wrong page. But yeah, it's there. Okay.
That's obviously an auto spell correction. So yeah. We'll make sure that's recorded and changed to empowerment. Thank you. And John Tomlinson, please.
Yeah, thank you. There was a typo on page 7, just the spelling of role, so it's a minor thing. But on page 11, just a question. Do we have an update from the Community Planning Board consideration of the paper, which we had considered previously on the locality planning?
Yes, I can give that, or perhaps Angela would like to step in. The Community Planning Board approved the paper and approved the recommendations. Yes, Angela.
Nothing to add to that, Sarah. It was warmly welcomed, the proposed approach.
Good, thank you.
Okay. Right. Leslie, do you want to come back in? No, okay, that's fine. So we'll make sure that the spelling errors are noted and corrected in this minute of this meeting as well. That's page 12, page 13, page 14, page 15, page 16, page 17. Right, so we're happy to approve those minutes with the corrections as noted. We're on to the minutes of the Clinical and Care Governance Committee of the 24th of November. This is for noting. Leslie, have you got anything you'd like to bring to our attention from this minute?
Just a couple of things in terms of, we had some feedback from the clinical justice social work inspection. You know, there's been quite a long delay in that, and you know, it was really just saying about there would be feedback on the 2-week engagement which had happened in November, and there'll be follow-up as we know about that. And also just we had a very positive report around the COVID-19 response in care homes, just giving us again an update on assurance arrangements for care homes in the city. And also I think maybe just going forward, the monitoring and evaluation of primary care in Scotland report, which obviously maybe just be worked through a little bit in a local context. Thank you.
Yeah, and I note that you've asked the clinical director to provide a report on the implementation of the recommendations in the city in November to your committee.
Yeah, thank you.
Thank you. Okay, and okay, we're now on to the business planner, page 27. Yes, Sandra.
Sorry, did you want me to give the update to Howard?
Oh yes, sorry. Yeah. Yes.
Sorry.
I've got a brain like a sieve at the moment, unless it's written down, I forget it. So
that's okay.
I think Caroline's left the meeting.
Yeah, she has. Yeah, just conscious of that. So the update would be that with regard to the decision made round about the 2C practices, there has been one practice in particular where there's been some concerns raised by the practiced by members of the public and by some groups. So the decision has been made to have that looked at independently. So an independent investigation of all of those complaints and concerns that has been raised is currently underway as part of our the IJB complaints process stage 2. So when we have the findings of that and the outcomes of that, I'll be able to take that forward with the chair and vice chair as to determine what our next steps and how we'll feed that back. Hopefully that covers what you're looking for, Howard.
Okay, yeah, thank you.
Okay. Yes, John Cook.
Yeah, thanks. Just to ask, time scale for the investigation. Am I right in thinking that's about 3 weeks or thereabouts?
So the timescales are within I think it's 20 working days. So it's the 5th of February. They should be back with me. Then we'll work forward from there. But there is set timescales that have been responded to.
Thanks.
Within our complaints procedure. Sorry, I've thrown my head's the same as Sarah's this morning. It's 20 working days, I'm fairly sure.
Yeah. I'm happy to give the board assurance that although we might not be able, we almost certainly won't be able to share the full report with the board because there'll be confidentiality aspects in there. We will certainly share a summary and details of all the findings. So we'll bring that back to a board meeting because we need to be open and transparent about this. Okay, any more comments on that? Yes, John Tomlinson.
Sorry, Chair, not on that. I'm just wondering, you've got an item 6 on the RAP committee and whether you want anything on that. It's just a question.
Yes, that was yesterday. So give us an update on what happened. Yeah, please. Thank you.
Okay, thank you. Just to highlight, we had a first look at the finance report from the Chief Finance Officer, and that's coming on the agenda at item 11, so we can say more about that at that point. We had a very good presentation on Operation Home First, which was a prelude to a report on the evaluation and performance coming to our next committee in April. And I think the Clinical and Care Governance Committee will also be interested in aspects of that, so can look at that for their next cycle. We had an update on the Strategic Risk Register, and as requested at the workshop we had in October, had a first look at hosted services in particular, but noted that there is a pending NHS Grampian audit report on that. So once we've received that, we will have a further consideration of that particular risk. And we agreed the internal audit plan. We also had a couple of reports around social care commissioning services, contract monitoring, and received quite a lot of assurance on the work that has been undertaken to sustain providers in the city, which has been really important work on, I think it's £86 million worth of our budget goes into that, and there's been all of those providers have been sustained. So that was very good assurance given the current situation. So that's just a snapshot, and obviously we'll see the formal minute once that's ready.
Okay, thank you very much for that, John. Right, we're on to item 7 now, which is the business planner. Sandra, is that you? Oh, Alex is here. Shall we drop him in the deep end since he's just appeared?
Yes.
Yes. Good morning, Alex. You're on mute, I'm afraid.
Oh yeah. Sorry, yeah, sorry, a wee bit late there. But okay. So in terms of the business planner as it sits at the moment, we've got the items that are on in relation to today, and you can see there that all of these are covered, and Martin's added something around about the EU exit into the SEO report. And on the meeting on the 23rd, there's a few of these reports that are being delayed. I think officers would like to have another look at these reports again and just see if there's any other ones within there that could potentially be delayed as well, just given that we've moved into the sort of civil contingencies and in the second wave, just to help out with some of the staffing situations that we've got at the moment. So the position is as stated, and there's an update on each of the items in the planner there. For the ones that there is no update, we're having another look at them just to see where we could drop them in.
Okay, yes, I mean, I think we've rightly taken the decision that we're going to continue with our pre-planned cycle of meetings, even though we're in the kind of top level response to COVID. But I think that means we have to be a bit pragmatic about items coming to the meetings over the next few months, because staff are understandably fully engaged in dealing with the current pandemic and winter surge pressures. So that's why some of the items that are already listed for February are going to be delayed further. And we might give some consideration to whether some of them can be put out as service updates. And of course, people can ask for them to then be discussed at the IJB, but we do need to be mindful of the work pressures on the team. I think there is an item missing from the February meeting, which is the medium-term financial strategy. That's our budget, so that will be going in the February meeting. That'll be after the partners have had their budget settlements in the Scottish Government and have made their budget decisions. That's an additional item on the 23rd of March. Does anybody have any comments or questions on the business planner? No? Okay. Yes, Mike Adams.
Yeah, it's not so much on the business planner, Sarah, but just on the general bit on what you just spoke about just now. So within staff side at NHS Grampian, it's been we have supported the fact that there are many things, unfortunately, at this moment in time that need to be paused. And the rule of thumb, even for the staff side meetings, etc., is the bits that come under the priorities. Operations Snowdrop are the ones, and that is mainly staff health and well-being, etc., are the ones that we give priority to. Although if something comes up that is really bad, then we can bring that up. But as I say, it's a general acceptance that at this moment in time there are certain things that need to be paused.
Yeah. No, I welcome that contribution, Mike. I think we all have to be very mindful of that. But we do have a very important assurance role on this board, and we wouldn't be fulfilling our duty if we didn't look at anything over the next few months. And so we will be focusing on matters directly related to the COVID response and also to high risk decisions that we have taken recently, like 2C. Where we need to keep getting assurance that that decision is being followed through. Right. Any other comments on the business planner? Okay, so we're on item 8, the Chief Officer's report. Sandra.
Thank you, Chair. The report before you is just really for noting. It gives an update on both local, regional and some national changes. I think the key things that I would just like to 3 key things really to draw attention to would be the criminal justice. We've had sight of the very draft report, and that's currently sent back for factual accuracy. We've just submitted that, so waiting for the final report. But unless there's very large changes, that initial feedback appears to be quite positive. So we'll look forward to that being shared with the board. The Granite Care Consortium, I think there's an update in there as well. And again, just to say that we continue to work in partnership. And our colleagues from across both procurement and our colleagues in-house and care management, it's a huge concerted effort to help that move forward. And the only other key thing is just, I think you've already highlighted it, Sarah, is about the Operation Snowdrop and the impact that that's having with regards to the team and how they're focused on that, both from support and vaccinations, support and surge and flow, seems to be 2 of our key areas. But we'd just like to note with regards to that, I'd like to note my thanks to the team and just be mindful that the resilience of the team is fundamentally been and has been stretched for a while. So it is really good to hear the support from both staff side and from the board and moving that forward. And also like to recognise the support from our partners, both NHS but particularly as well with the council, and how we're able to start to get that resilience and really share the resources across the system to get that wider system help. And that's really all. Just any questions from there.
Okay, thank you, Sandra. John Cook and then John Tomlinson.
Thanks. Yeah. First of all, just to say the presentation that some of us had last Friday on Operation Snowdrop was very, very helpful. So thanks for that. And then I've got a question on the Granite Consortium. Bonacore Care have left. Do we know why that is, and what impact could it have on service delivery?
So I'm not fully aware of the reasons for their leaving, but with regards to the impact on service delivery from the Granite Care Consortium, it's not had an impact. So Bonacore Care are currently undertaking some additional work with hours and care at home support hours for us. So as part of the surge in flow. So no, it's not my understanding that it's had any degree of impact.
Thanks. Yeah, I was just kind of curious, given that the consortium's only been operating since 1st of November last year. It seems like a quick change, but if we can get assurance, if there's assurance that service users aren't impacted, then I'm relaxed.
Yeah, no, absolutely not. I think the one thing about the Granite Care Consortium and the way that we've set up the procurement and the contracting on this is we're all very keen that we are learning. The Granite City Consortium have got I think the impact of service users at its very heart there. So, and we're doing it. It's absolutely one of the key drivers for working together. So no, there hasn't been.
Okay, thanks.
Thank you, John Tomlinson.
Yes, thank you. Basically, mine was the same question, so I was considering whether to come in or not. But I think there is an aspect of this, and it's the rationale that we had of having a group of providers in areas so that they would get efficiencies across the board. When possibly they're the biggest of the providers is not in there anymore, there is a question there about what that does to the rationale of it. So appreciate you may not have answers just now, but I am curious about that. So if you could get something at some point, thanks.
I could give you some feedback on that just now, John. So Bonacore Care are a large delivery partner, but where and how they're delivering on behalf of the partnership is slightly is different in some contexts than how we're approaching with the Granite Care Consortium. So we're absolutely embedded in localities, but with Bonacore Care and the contract that they have and the flexibility we're looking for them around surge and flow and different aspects is actually bringing in additionality to our locality working instead of detracting from it. But they absolutely can take on board and bring back some further description, or if you would. I'm not quite sure what the ask is directly that you're asking. So
I think it might be helpful to get an update and circulate it to board members about what Bonacore Care's role was in the consortium and how that role is now being covered. My understanding, and I could be muddling up various pieces of information I've had, was that Bonacore Care were more of an administrative support role rather than providing carers going into people's houses. I think that was always the intention. That was always going to be their role in the consortium. So, but I could have got that wrong, and it would be useful to get confirmation of that. So if we could circulate that out to board members when we've got a kind of clear answer for both John's questions, that would be good.
Yeah, thank you very much, Chair. I think that would be useful. Just basically being assured on that, and I do appreciate once you get into the implementation, then things can shift and something different can be sensible. But it's just from us in terms of our governance, understanding how the rationale or the conceit of it has shifted. That would be fine. Thank you very much.
Yeah, I think we've also got a report on Granite Care Consortium that's been referred back from the Clinical and Care Governance Committee, and that's coming, I think, to February. I mean, this is where my mind's being a sieve again, and it's just been on the business planner. But we're getting an assurance report because there's been a huge increase in the number of care at home hours needed because of the pandemic, and we just wanted to make sure that the board were fully sighted on what's been going on in care at home.
Thank you both. Thanks.
I think Alex, you had your hand up. Have you changed your mind?
Yeah, I've changed my mind, but it was just really to say I think the best way to deal with this will just be to get you a briefing note. I know you've already said that, and get some input out with the meeting to explain the rationale fully to you and get that closed off. I'm just a bit mindful that it was a decision of Bonacore Cares Board, and therefore, you know, we really need to go back to them and get that information and bring it back to you in a format that they were happy with.
Yeah, just so board members are aware, I've been invited to attend Bonacore Cares board meeting this Friday. So if there's an opportunity, I'll say that we've had this discussion today, just so Bonacore Cares board are aware. IJB board members have raised this. Right. Okay, any other questions on the Chief Officer report? Luann?
Thanks, Sarah. Just to sort of follow on about the emergency situation that people are working within just now, and as well as the IJB meetings and our committees still going ahead, we're also now receiving regular updates on the vaccination progress and also on care home updates. So, and I think my understanding, I just want to check with Sandra if there are other areas of risk or concern that Sandra will be looking regularly to see what the IJB needs updated, and that will be coming out through communications, through emails to the IJB members. So there's lots of ways that we will all be kept in touch. But Sandra, is that correct in my thinking? If there are new significant issues emerging, that you'll keep IJB members briefed with meetings as well? Yeah.
Absolutely. Yeah.
Okay. Thank you.
Yeah,
but
no,
obviously mindful not to put more pressure on people, but it's important we're updated on the risks.
Yeah, so we're getting frailty pathway updates, care home updates, and vaccination updates. So good, thank you for that, Luann. Right, we'll move on to the next item, item 9, the IJB Scheme of Governance. So, Mr. Forsyth, is this you? Or Kunda?
It's me. You get double the legal team today. So before you see is the annual review of the IJB Scheme of Governance. And this year, we're going to be looking at 3 of the IJB's governing documents, which is the Role and Responsibility Protocol, the IJB's Standing Orders, and the Terms of Reference for the IJB subcommittees. So given that the document is quite extensive, I thought I'll just give you a brief walkthrough of some of the changes that have been made. So starting off with Appendix D, which you'll find on page 82, that would be the Roles and Responsibility Protocol. And in that document, minor changes have been made to the style and format of the document. And on page 82 itself, section 1 has been updated to just reflect the date of when the changes will be approved, which will be today if the members wish to approve the document. There have been no further changes that have been made to this document apart from that. Now, moving back upwards to page 45, you see the terms of reference for the RAP committee. And in there, page 48, section 7 has been amended, and section 7 is the one that deals with the conduct of meetings. So it's just been updated to remove any repetitive wording. And further down, page 50, sections 10, subsections 11 and subsections 12, they've also been updated to remove any repeated wording and to provide a bit more clarity as to how the meeting for the RAP committee is conducted. Now, if we move to the clinical care governance terms of reference, which you move back down to page 57, section 6, subsection 3, which talks about the frequency of meetings, has been updated once again. This is to remove any repetitive wording, and this has also been done with section 7, which talks about the conduct of meetings, and section 10, which you'll find on page 58 of your pack, which talks about reporting arrangements. Finally, if we look at the IJB's standing orders, which are in Appendix C, which is on page 64 to 66 of your pack, if you go straight to page 64, you will note that Standing Order 11 has been updated. And this is following the IJB's meeting on the 24th of March 2020. At this meeting, the IJB agreed to add a new temporary standing order to make provision for remote meetings during the pandemic. And the plan was to keep these temporary changes and to have them reflected permanently in the standing orders. So all that has been done is just take the temporary wording, copy and paste it into the standing orders, and everything is exactly the same as what was agreed on the 24th of March. And on page 78, you also note that there's an Appendix A. So this appendix is just providing guidance on attending remote meetings via Microsoft Teams. If you move further down to page 78, Standing Order 25 has been changed. Now, this standing order talks about the term of service for chairs and vice chairs for the IJB subcommittees. Normally, the wording for this section would say that the vice chair and chair for the IJB subcommittees will sit in office for a period not exceeding 2 years. This term has been extended by an additional year, so the vice chairs and chairs for the IJB subcommittees, which is the REP committee and clinical care governance committee, are now able to sit for a term which is not exceeding 3 years. So it's now 2 plus 1 year. And if you move further down to page 76, Standing Order 29, which talks about deputations, has also been amended. And this is just to provide clarity on decision making when it comes to deputations. I'll hand over back to the chair to take any questions from the members.
Okay, thank you, Kundai, for that summary of the changes. Any comments or questions from members? Philip.
Thank you, Chair. It's obviously quite a complex document. I found it quite hard to actually chase through the changes. They're not actually obvious. So, I mean, for instance, on page 40, under 3.4, it actually says roles and responsibilities protocol outlined in Appendix E, but it's actually Appendix D. And then 3.5.1, it says section 9, 5 and 6. That should be section 10, 5 and 6, and so on. So I'm wondering, I've not actually seen this on any of these documents, but would it be a good idea to actually indicate against which sections have been updated with just a line in the paragraph?
Yeah, my understanding, Philip, we asked for that at the pre-agenda stage because we do appreciate these are long and complicated documents, but the system for producing PDFs and also for issuing documents on ModGov doesn't allow for marked up versions to be included. So that
I'm not sure if that's true actually, Chair. If you have a Word document, you turn it into a PDF document.
Right.
You still keep that. Oh, and I should actually say as well, again, 6.3, the summary of the risk register hasn't been updated.
Which document are you talking about, Philip?
On page 43, 6.3, there's a summary of the risk register. That actually is an old risk register.
Can I answer that, Councillor?
Yeah.
So in terms of 6.3, I'll start off with that one first, if that's okay, Councillor Bell. That was taken from the actual Aberdeen City Health and Social Care Partnerships website where the strategic risk register sits. And I do apologize that I didn't double check that against any other risk register that's out there, but that information I did get from the website, so that might need to be updated, so I do apologize for that. And in terms of the typos that you mentioned in sections 3.4, and I can't remember the other section, those are definitely typos that did come up, and I did spot them when I was going through the document, so I do apologize to all the members for the typos. And in terms of track changes, I'll reiterate what Councillor Duncan has said. I have been trying to work with committee services, and they have confirmed that they're not able to, with the system that we have at the moment, they're not able to demonstrate the track changes. But if you look at some of the pages on the document, particularly when it comes to page 64, you will notice that it's slightly gray. And I know slightly gray against black, it doesn't provide much clarity, but that's the only way that you can note that there are changes within the document. Other than that, it's not as evident as using Microsoft Word where the track changes are in red. I'll hand over to Derek because I think Derek just wants to add something on about that.
Okay, Derek. Yeah.
Thank you, through yourself, Chair. Thanks for that, Kundai. As Kundai has said, that there is a challenge about reproducing a track changes in Microsoft Word environment into the PDF and the mod.gov world. I have been working with Kundai to try and get a package created in a MS Word format that will be able to show the review stages of the document, which will indicate where the changes are made and when and by whom. Sadly, I'm dealing with COVID at this time myself, so I haven't had the energy to go and do some of that work. But I will be following it up post this meeting and into next week with Kundai. So I would like to be able to give the committee and the board a promise that once we have a better reviewed document style, we will be able to show the full revisions that Kundai has made to the document packs.
Thank you. I hope you have a speedy recovery, Derek. I'm sorry to hear that you're not great.
Yeah. Yes, thank you. I think it's Leslie next and then John Cook.
Thank you, Chair. My question's really in terms of the terms of reference for the clinical and care governance. It's on section 6.4, which is page 57. And I just wanted some clarity around the abbreviation in the final sentence, when you're saying the urgent business meeting shall retain all the AP's functions and powers. Just what AP is.
Sorry, that was.
And if you can, state it, without an abbreviation.
Sorry, that's an abbreviation that I'll need to look into and update, because I think it's supposed to be audit and performance, but I will double check that and update that. So I do apologize for that.
Okay, and just finally, thank you for all your work on this, Kundai. It's a considerable task to bring all this forward to us. Thank you.
Okay, I think that AP should be Clinical Care Governance Committee's functions, because we're referring to retaining all the powers of the committee, even if it's an urgent business committee. So that's 6.4 on page 57.
I'll make that change.
Okay, John Cook and then Angela.
Thanks. Just initially to say, in terms of Kundai apologising for some of the typos, if I get through one page of A4 on a document I've done without a typo, it's cause for celebration. So I wouldn't beat yourself up too much on that. Just a couple of questions. The extension in the time for committee chairs from 2 years to 3 years, just wondered what the rationale for that was.
So through you, Chair, Councillor Cook, that's in line with the legislation for the IJB. It does allow for vice chairs and chairs to sit for a period of 3 years, but that has not been reflected in our terms of reference or our standing orders. So we thought to just allow the maximum period, just in case there is a time where there's a situation that won't allow for that, that prevents a chair for sitting for an additional term if there's an extenuating circumstances that comes about. So it's just an additional year that's there. The chair doesn't need to sit for that duration, but it's an option that is there. And then when they do join, that option is available to them.
I think that's helpful. I was just curious as much as anything else. And then the other question relates to in the standing orders. I think it's on page 70. I think it's number 19, which is the provision where we can't change something within 6 months. Is that new, or is that an existing one?
That's always been in. That's been in since the beginning.
I thought so, and there is something similar at the council.
Yeah.
If I'm reading it right, I think I'm okay with it. The question I had was, if there was a change in circumstances. I'm thinking about, you know, the new variant COVID, where how things were being done, all of a sudden new variant comes along and things needed to be changed very quickly. If I'm reading that right, that wouldn't preclude us from making a very sort of short-term change in direction on something, would it?
That is correct, Councillor Cook. There is provision. I think it's in the second line of that standing order for the recommendation to be made to the IJB to change a previous decision that has been made. But that recommendation only can happen if the members approve it, and that change has been approved by the chair for that item to be brought to the IJB for any changes.
Thanks, that's really helpful. I thought that was the case, but I just wanted just to double check. So thanks for that.
Okay, thank you, John. Angela?
Through you, Convener Kundai, thank you for the work that you've done on the governance documents. That's much appreciated. I noticed in the Chief Officer's report the reference to Scottish Parliament laying regulations to recognise IGBs as Category 1 responders, which is a welcome approach from the Scottish Government. I'm just curious around whether we anticipate any implications of those regulations needing to reflect them in the governance documents of the IGB, and that might be unfair because you may not have had the opportunity to look at the regulations, Kundai, but in the event that we may, I wonder if the board today should be, if it chooses to approve the documents that you've presented, to note that we might need to reconsider all of the governance documents in light of the requirements from the Scottish Government regulation around Category 1 responder.
Yes, I would accept the additional recommendation to be added to the report. I hadn't had time to look into that as yet, but I do appreciate that that might make changes to the documents that we have before us today.
Okay, thank you. Derek?
Apologies, Chair, that's a stale hand.
Oh, that's all right. Okay, fine. Okay, right. I think we should move to the recommendations then. Thank you, Kundai, for your very helpful explanations of this and for all the work that's gone in. I'm going to... right, so recommendations are on page 39 and 40. So we're being asked to approve the revised Risk Audit and Performance Committee terms of reference in Appendix A. Can I add into each of these recommendations as proofread for typographic errors? Because I think there might be some typos that we need to pick up, and I wouldn't want us to approve standing orders that had typos that might be confusing to the interpretation. That could lead to difficulties later on. Kundai, is that a rational recommendation?
Yes, it is.
Yeah. Okay. Angela?
Sorry, legacy.
Okay. Okay, so for every recommendation here, if we could amend it with the wording to reflect that we want the version as proofread for typographic errors to be the one that we're approving. And I think we need to take this, I think we need to take them back to the board for noting the clean copies at the next meeting as well, just so we're all very absolutely clear what we're agreeing today. I think it's fine to agree it in principle today, but we need just to kind of cross the T's and dot the I's on this at the next meeting. So approve the RAP terms of reference, approve the revised clinical and care governance terms of reference, approve the revised standing orders, and approve the revised roles and responsibilities protocol. And we're asked to note that Aberdeen City Council is reviewing its scheme of governance at a report on this council meeting in March. Changes will be evaluated insofar as any impact on the business of the Health and Social Care Partnership or the IJB and its subcommittees. And the Chief Officer will bring an update to the IJB meeting immediately following the March 21 Council meeting. So that update should include the final corrected versions of all the terms of reference, and also some consideration of whether the terms of reference need amended to take account of the new regulations on being a Category 1 responder. So I think we can incorporate Angela's point in recommendation F and bring everything back for noting at the March meeting. Is everybody clear on that? Derek, a new hand.
Yes, it is a new one, Chair. Thank you very much. Can I suggest that instead of approving on this time, the wording says you have agreed each of these changes, which will be returned to the March board for approval?
Yes, that's fine. Thank you for that. Thank you.
Okay.
Philip, I saw your hand. Have you changed your mind?
I did, and that was so after Derek had just made that comment.
Okay.
Going to sweep up all the things. Thanks, Derek.
Okay, so we're agreeing the changes and we will formally approve them in March. Fine. Sandra.
Just a request, Chair, from you'll be aware on the agenda that we have the Bonacore Care Annual Report next and then a vaccinations update. I'm aware that David Flegger had planned to come to the meeting today to support the vaccinations paper. He's the SRO on vaccinations for NHS Grampian, but they're also trying to cover in an Aberdeenshire committee as well as here. So wondering if you could possibly, if we could take that paper now, if that was okay with yourself and with the author.
The vaccinations paper. Yes,
yeah.
Of course. Yes,
is that okay?
Of course.
Yeah.
Happy to do that. Yes.
That's great. Thank you very much. I think David's just joining us just now, so that'll be there.
That's fine. Right. So just to confirm, we've agreed the recommendations as amended on item 9. And thank you again, Kundai, for all your work on this.
Thank you.
Items like this make me thankful again that I'm not still a solicitor, I have to say. Right. Okay. We'll skip up to item 12, which is the vaccinations update on page 127 of your packs. And you're very welcome, Mr. Flegger. Thank you for attending the meeting. Okay, would you like to introduce the report, or is somebody else going to do that? Andy, is that you?
I think Alison's going to introduce our report.
Fine.
Thanks, Sandra. Thanks, Chair, and apologies, but I will keep my camera off. It appears to interfere with the sound quality of my Teams, so apologies for being slightly incognito. But the report that you have in front of you, you'll recall the Ijb requested an update on all of our immunisations and vaccination progress. So the paper in front of you covers an update on childhood immunisations. The data that we have available to us takes us up to October. We are expecting full year data next week, so that is the most up to date that we can provide you with at the minute. You also requested, as you'll be aware, we've had lots of discussions around about the flu vaccination programme at Ijb, and you requested a lessons learned report. So that is Appendix B of this paper, and we've tried very much to focus on the particular areas that have been a focus of discussion at Ijb, and concentrate on the lessons that we have learned from that and how they have fed into planning for the COVID vaccination programme. And that is the final appendix in this paper. You asked us to give you a kind of up-to-date position as to where we were with COVID vaccinations. So that's the paper in front of you today. As you're aware, we've got colleagues with us to help answer any queries. We have Joe Hall, who is programme manager with the partnership, obviously, and has responsibility for childhood immunisations and led on the flu vaccination programme along with colleagues from community nursing. And we have Sandy Reid, who is the partnership's lead officer for the COVID vaccination programme. So if there are any questions, hopefully colleagues here can help respond to them. Thank you.
Thank you, Alison. Right, questions and comments from the board, please. John Cook and then Philip Bell.
Thank you, Chair. Alison, can I say when I read this paper, I thought it was absolutely excellent. What I really like, I particularly like the appendix on the flu vaccinations, because it doesn't pull any punches in where things could have been done better and could have gone, have gone wrong. And there is quite a lot of literature around the fact that organisations that are willing and comfortable in saying we got this wrong, we could have done it better, are far more successful than organisations where the temptation is to gloss over the things that went wrong and say, yeah, everything was fine, but one or two little teething problems. So I think the fact that this is such a candid report is absolutely excellent, and it gives me as a board member confidence that we're getting the right information. So thanks and well done. I'd say this is an example of good practice, and that ought to be kind of trumpeted across the organisation. Having said that, we actually did 1.9% more in the over 65s and 8.1% more in the at-risk groups, despite the fact that you were having to do all this stuff with social distancing in the middle of the pandemic. So just really well done to all concerned. I'll say an absolutely excellent report, and thanks and well done.
Thank you, John.
Thank you. Yeah, no, I think it's important, given that we're in the middle of COVID vaccinations, possibly the single most important public health intervention ever, that we learn from what happened in flu. But it shouldn't detract from the amazing piece of work that was done in flu vaccinations, given all the restrictions, all the challenges that we've had. And it's paragraph 3.5 on page 128. To vaccinate more people against flu, given everything that's going on, is exceptionally good work. So, Philip Bell, and then Luann, please.
Thank you, Chair. Councillor Cook, you stole all my thunder. I was going to say almost exactly what you said, not quite as eloquently, of course. But I do have a few questions, of course. The 6-in-1 dose. I'm just wondering what the target vaccination rate is for that. They're the dose. Oh, I'm getting confused here. Hang on. The 6-in-1. I think it's 95%. What about the MMR target vaccination rate? Because that isn't, the target isn't actually specified.
That's page 132.
Yes.
Okay.
But it's also summarised on 3.2 on page 112, right? That just talks about a target for the 6-in-1, nothing else.
Yeah, I think I see Sandra's hand. Is that you're coming in on that, Sandra?
It was just a query, Chair. It's just that we're aware that we've got part of the figures for the childhood vaccinations, and we're also aware that given the focus that we've had on vaccinations as an IJB over the last year, and did wonder whether we should bring a more fuller report answering some of these questions that Councillor Bell's raised into our Clinical Care Governance Committee, just on a Pacific on childhood vaccinations, where we are with that, and then if there was any concerns, it could be escalated to board.
Yeah, how do you? I think I remember hearing that the latest figures are going to be out next week, so it's a timing issue, isn't it?
Yeah, absolutely. Yeah. Absolutely, yes. Yeah.
I'm comfortable with that. Is everyone else? Philip, would that satisfy you? I mean, we can probably get you an answer on the target rate. Maybe somebody could answer the target percentage question just now. But
that will be good. But there's also, I mean, as part of that report, I'm intrigued to see how the numbers of vaccinations fell off in October for dose 2 and 3, but not for dose 1, for instance.
Yeah, I think there's complex underlying reasons for this, and it would be really useful to get that to CCG, I think. Yeah. Jo, do you want to come in?
Yeah, just on that, Chair, I think, that is something that we could bring back. I think that would be helpful for the board to see that, and that's something we can prepare and bring. Just on the MMR dose 2, just I guess for information, we deliver the MMR at 4 years, and nationally the data is pooled at 3 years and 4 months. So that's why there's the kind of inconsistencies with the way it's captured in the report, because obviously that's the national reporting that's presented to us. So that's something that we're aware of. That's something that's being discussed locally in terms of that move to that 4 years, and actually what is the right thing to do. I think when it was first implemented, it was convenience round about families and carers, because they were doing their 4-year reviews. So they did the immunisations at the same time. But actually, if the nationally reporting and pulling the system at 3 years, 4 months, we need to review that and be in line with other boards. So that's something that we're aware of.
Right, thank you. Thanks. I have a couple more questions, if I may, Chair, please.
Yeah.
On page 123, there's mention made of the national vaccination management tool, and I'm just wondering how that is accessed, how that tool is accessed, or by clinical staff.
Would you like me to cover that? So the vaccination management tool, it's accessed through TURAS. And I think, obviously in terms of our lessons learned from flu, a lot of it was paper-based. There was that delay with getting that recording information back into patient records. So that was a huge challenge. Going forward for COVID, all immunisations will be recorded in the vaccination management tool at time of immunisation. That is through iPads that have been provided nationally to us. So each vaccinator will have an iPad. They have a TURAS access login as a vaccinator, and that's all recorded directly into the system as to whether they received it or didn't receive it for any reason. And that information is then pulled nationally so that we can see the uptake. That information also goes back into GPIT, so it goes back into the patient records in the system, and that was a huge challenge around about flu. So obviously that kind of development nationally is really welcome.
Oh, good. So that also means then that clearly you'll know when somebody's had the first vaccination, you'll know what vaccination they had, and you'll therefore know which vaccination they need to have and when. Second, yeah.
Yeah, so in terms of the appointment letters for the COVID vaccination, when we're providing the appointments, we're in the letters they're being issued with their dose 1 appointment and their dose 2 appointment at the same time. So they will have those 2 dates in that initial appointment letter that they're receiving. But yeah, you're absolutely right, Rand, about that vaccination management tool will capture the type of vaccine that they're receiving.
Right, thank you. And then final question, please. So this is with regard to the tabulation on page 125, which actually just lists the number with the different cohorts and the numbers that are going to be vaccinated. So there are some gaps in it in terms of numbers. I note, so and also the way it's actually presented is curious. So if you look at the bottom. The bottom group, age 16 and over, well, 50 would come into that group, as would 55, as would 60. So should there not be age 16 to 49, for instance? And the next one, age 50 to 54. So there's absolutely no doubt at all. Is it, or am I just being rather foolish with my comments?
So I guess on that, we're obviously working to the JCVI priorities, and the list that's in that table is those JCVI priorities. But there will be, the cohort information is coming through to us nationally, so it is being provided. We are cleansing data prior to appointment letters going out, so there will be an element of individuals being on both lists, but I can assure you that we are cleansing the data to remove those. So for example, our clinically vulnerable, there will be individuals on that list who will have already been invited through their age cohort, through the over 80, through the 75 to 79, or through the 70 to 74, because obviously in terms of that ordering, we then move on to that clinically vulnerable. So that data cleansing is taking place prior to appointments letters going out. But I see David's hands up, so he might want to pick that up.
Is that okay, Chair? Can I come in?
Of course, yes. Yeah.
Okay, so yeah, I would agree with Councillor Bell. They are taken from JCVI, but clearly age 55 and over is actually the 55 to 59 additional cohort. Joe's absolutely right in saying that there is crossover. So if you are in a clinically extremely vulnerable group, for example, you're a transplant patient or you've got a tumour, then you will fall into one of those other age categories, which is possibly why those numbers aren't there. But in terms of clinically extremely vulnerable, we know we've got a cohort across Grampian of around 15,000. And in terms of the aged 80 over in hospital, clearly that is a movable feast. So it will change from day to day, and it's just simply that we are recognising that cohort and needing to do it. So, for example, just before Christmas, when we looked at the number of patients aged over 80 who were in hospital for a period of 30 days or more, that number was around about 100, which is, I guess, demonstrates the small size of that cohort in terms of long stay. But what we've moved to since then is we're now opportunistically vaccinating those aged over 70 who are an inpatient, who are clinically appropriate to receive that vaccination. And we're also vaccinating all patients who are likely to be discharged to an older people's care home regardless of age. So if you were 59 and you were going to go to an older people's care home, then you would be we would seek to vaccinate you whilst you were an inpatient, if at all possible. Clearly that has to fit with the patient's condition. Clearly it has to fit with the patient's treatment. And what we've said is that if we aren't able to do it as an inpatient, then they will be picked up when they go back out into the community. If they're going out to a care home, clearly there's a desire to have them vaccinated before they go in. So yes, in essence, Councillor Bell, yeah, you're right. It's those cohorts are the additional age groupings as we go down. Hopefully that answers your question.
Yes, thank you. Thanks very much.
Okay, thank you, Philip. Luann next, and then Kim.
Thanks, Sarah. First of all, just to say I think it's a really good report, and thank the teams that have been involved to date, and the work that's going on this year is just incredible. A really impressive, huge system effort. So really, really thankful for all the teams involved in this. Just to echo, I really think I'd welcome a report on the childhood vaccination once we have the full data for the year. What I'd be interested in seeing is where we are around targets and are we meeting targets, but also if there are any groups where there's been lower uptake, what our plans are around reaching out and engaging with groups where there's traditionally low uptakes around childhood vaccination. So just to add that in as a comment. My question is really around the whole population COVID vaccination, and whilst I get TECA is a good, very, very good location for that. It's the safest and most efficient way of doing this huge population vaccination. I just wanted to understand a bit more about what's in place to make sure that we're not leaving anyone behind. I'm thinking of people maybe with complex mental health issues or difficult lives where that actually being able to get to TECA is just going to mean they won't be vaccinated, and just making sure we're taking care not to widen existing health inequalities that we have in some of our communities.
Andy, I see your hand.
Thank you, Chair. If I maybe just try and answer the question about other options than PNG Live, I think that was kind of the main thrust of the question. So just to understand, what people will get initially is a letter inviting them to an appointment at PNG Live. But as in that letter, we then talk them through and highlight to them through links and phone numbers other options that so they may not be able to travel there independently, so they give them public transport information. They may not be able to access that, so they give them the Think transport system that works across Grampian, that literally sometimes takes people to their venue and literally comes to your door and picks you up and takes you back in. And that's a well tried and tested system that works across Grampian, taking people to hospital appointments, if we just assume this is a hospital appointment. And then if that is still not going to meet people's needs, then they have the option again on the letter to contact our contact centre that we've set up, where ultimately, and we're just starting this process just now, we're going to sort of have pop-up community venues, which will be then people will then be booked into those venues as there is enough people to book into a venue for vaccine and vaccinators, but also is close enough for them to be able to access, if no other examples. So for example, there are no community venues next week booked. All letters and all if you like, all roads lead to P&G Live, but we have provisionally this morning put in the diary and booked 2 community venues on the Tuesday and the Thursday of that week, potentially from 9:30 to 2:30, because that's the best time for getting people from vaccine to provide vaccines to the workforce, because it's child friendly. And maybe they will be in Torry and Westburn Lounge. So the idea would be you go through all those different options, and you've got probably 6 or 7 options before you get to that option. Then you come back to our contact centre, who talk through all of that with you, and on each of the slots for each of the days, there'll be empty slots to book people into on Tuesday the 9th or Thursday the 11th. So that's it's probably short as somebody I could give. Hopefully that answers the question, Chair, but I'm happy to expand on that if there's any other questions.
Joanne, do you want to come back in?
Thanks, Sandy. That's really helpful. I suppose I'm thinking of people who maybe don't open their letters, and you know, of our more complex folk, and whether are we engaging with our third sector to just make sure people understand, you know, there's health literacy issues in amongst that as well. Whilst I think what you're doing sounds very good, it's just these people that are on the edge and often miss healthcare appointments that I have in my mind. So yeah, just if there's support around that from trusted services, that would be helpful to hear about.
Chair, do you want me to come back? I'm conscious David's got his hand up. Do I carry on, David, or do you want to come in first?
No, Sandy, you can carry on. I'll
okay,
pick up.
Thank you. Just to go back to an example that was mentioned there, some of the clinics for staff were held at Royal Cornhill Hospital that hosts mental health and substance misuse services. So that, in short, the plan would be for, say, someone with a particular behaviour or set of issues that wouldn't make them, they wouldn't want to go to even to a community venue or a P&G Live. The proposal is that Cornhill colleagues, to use that shorthand, would invite staff that they know, patients that they know, to specific clinics quietly and sensitively within the environment which they're already familiar with, if I can put it in those terms. So that would include specifically mental health and specifically substance misuse, and probably people with learning disabilities who had maybe perhaps challenging behaviours. So they would be known to the service and brought back in a sensitive way within the service. Hopefully that answers just I understood, sorry, I kind of focused on the second part of that. Thank you.
Thanks, Sandy. That's exactly what I had in mind. Thank you.
Right, David, do you want to come in?
Yeah, it was just really to go back to just emphasise that the most efficient, fastest way to roll this out is the big centres. So as many people as we can get to go to those centres, the better the quicker they will get vaccinated. There is no question. So as an example, there are a number of outpatient departments who are quite interested in opportunistically vaccinating patients as they come through the door. It's particularly in the clinically extremely vulnerable category. The problem is they couldn't do all of those in a week, whereas we can if we use the mass vaccination centre approach. Now, there will be groups that that opportunistic approach will still be valuable for. So for, as a specific example within mental health, patients with schizophrenia are likely to feel more comfortable having a vaccination at their regular appointment. So we're working with those specific groups. And what I would also say is we're going to have to then go back and look at where we've not had the uptake that we would wish, and then have very focused approaches to those. So, but I think at the moment that push is around the mass vaccination centres, but no, the idea is to vaccinate the whole population. You know, and we'll have to tailor our approaches to that. So, for example, in other areas outside the city where we've got hard to reach communities, we're thinking, you know, how do we take the vaccine to them, either in their workplace or, you know, very close to where they are, because the aim is everybody who wants it and can clinically receive it, we need to offer it and encourage that uptake.
Okay, thank you. That's a very clear message to us. Kim, I'll bring you in a sec. I just want to abuse chair's privileges and make a comment. I think the comms around this, the public messaging, is incredibly important. And I mean, I represent a ward in the very south of the city. I am getting lots of grumbles about why do we have to go to Teca? Why can't you use the community centre? Why can't you use an empty building in the industrial estate at Alton's? You know, people are always helpful, coming up with helpful suggestions. I absolutely understand the logic of wanting one mass vaccination centre at Teca, but that needs to be clearly communicated to people. And once people start getting their appointment letters, and if they work their way through the letter and then work out at the bottom there's a local option, I think you might be surprised at how many people want that local option, which is a whole level of logistics and setting it up and everything afterwards. So I really do think the public communication about the decision that has been taken to have one mass vaccination centre at Teca needs to be crystal clear in the communications. Otherwise, we're going to spend an awful lot of time making the explanation to individuals rather than making it once globally. Do you want to come back in, David?
Yeah, I would absolutely agree, Chair. But I would also just add this as a comment. What we found in both, well, we suspect it's happened in the city. We know it's happened in Shire. So a number of those patients who are traditionally designated housebound in the over 80s category, who receive district nursing support, have chosen to go to their GP practice to have their appointment. So the motivation to have this vaccination is extremely high. Mm-hmm. So, and what we've done is reassured those people that just because they've managed to get to the GP on that occasion does not mean that they're going to suddenly be off the district nursing support list, because that's important too. But I guess it's just a flag that, you know, this is a scale up from flu. You know, we're talking about delivering 1.2 million doses of vaccine. That, I'm afraid, requires a different approach, but equally we do have to catch those who are unable to take up the offer that we're in the main providing. So yeah, it's just recognizing this is on quite a significantly different scale, with some quite challenging logistics around the vaccines.
Yeah, no, I mean, it's a mind-boggling operation, actually. So yeah, Kim, you next, and then John Tomlinson.
Yes, thank you. So Luann asked one of my questions, which is excellent, but if I can maybe perhaps add into the mix for clinical governance is the HPV vaccine and what's happening with that for an update, because that's something I've not heard mentioned at all in discussion just generally or even in the media. I'm very sorry if this was asked, and if it was asked, please I can get the answer offline. I'm so sorry. Someone came into my office with some bad news, and I got a little distracted before Philip spoke, so I'm not sure if this was asked prior to this. But I wanted to go back to flu vaccine and just looking at the numbers, and just around obviously improved numbers this year, but still just about 50% of our at-risk cohort were vaccinated. I don't know if there's anything around how that compares with other boards. But also it still seems a little bit low, although improved. And I wondered where childhood flu vaccination comes into that, and what the figures are around that, if we have any yet.
Wants to come in on that? Hi, Joe.
Yeah, hi, sorry. Yeah, so in relation to the at-risk, you're right, the numbers are up. I think, you know, I guess being in the midst of a pandemic, there were more people coming out to receive their immunisation. We did see some instances of almost, you know, quite a significant increase practice by practice. I think, you know, Luann touched on the, you know, in terms of those that perhaps can't access, you know, that's something we have the breakdown practice by practice, and that's something that will, you know, in terms of our lessons learned going forward, that's something that we will look at and really target, and really we've done an evaluation process with our patients as we were going through this for those that could get to venues and those that couldn't get to venues. So we're building on that, and that will be what will develop the programme going forward. So I guess in terms of how it compares, I think it's pretty much on a par across the health boards. I think a lot of health boards have seen an increase around about that at risk. You know, it's been fairly obvious within the city, but it can always be better, and that's something that we'll continue to work on. So that's the at risk. In relation to the flu, the preschool, the primary school uptake. The primary school uptake's been excellent, obviously, with lots of challenges in terms of into schools. Again, I think what I would propose is that we share that information separately, and that can go to the board in amongst the preschool information for information.
Chair, if I may, just as a follow-up to that, I just wondered around the messaging around the fact that we're still in flu vaccination season. I know everyone's thinking COVID vaccination, but that still, they can still get the flu vaccine within the city. And is that messaging quite clear to people that they can still get community pharmacy, etc.? Something gone out?
So we're doing a lot round about that. Obviously, it has now transferred to community pharmacy. That is just for our at-risk and our over 65 patients, as well as our 60 to 64. So that is kind of through social media. There has been some media releases. GP practices are aware. The uptake, I think, you know, there's a lot of people kind of obviously clearly, you know, the COVID vaccination, you know, is now in the pipeline. So I guess there's that we're working towards, but the messaging is still very much out there that there are still flu vaccines available. The flu programme runs until March, so you know there are vaccines available, but we will pick that up again. Yeah.
Okay. Sorry, my system's jammed up. I think it was John Tomlinson next, and then Alison.
Yeah, thank you, Chair. Yeah, like others, thank you very much for this report. It's extremely helpful, and it does warrant underscoring some of the earlier comments from, I think, Councillors Cook and Bell, just about the assurance from the transparency given here. Two quick asks, so probably not for answering here, but just when the full year report comes back, I'm looking at Appendix A around the childhood immunisations, and just in terms of reading that, I would be looking for the full report to be clear about not just monthly figures, but the cumulative figures. So it'll need to have some narrative to explain that for me as a lay person, but also then the protection between the 3 doses, and that's probably my ignorance in terms of understanding that, but that would help me understand the efficacy of that programme. So that's just an ask for when that comes through. And the second point would be, it is a longer term one, but I'm thinking about health debt here. So we're setting up what is an enormous programme, therefore has substantial workforce capacity around it. And then alongside this, there's test and protect, etc. So things are changing in terms of what are priorities to be produced, and we already know that our workforce is under enormous pressure. So not so much for answering today, but going forward, I certainly will be looking for some information around how the workforce is having to be shifted, or whether it can be expanded, etc., to take these up, and what the impact is in terms of what we're not doing. So it's just to flag that at this stage, Chair, not so much asking for answers today. Thank you.
Yeah, I agree with you, John. I think we need to consider, when the heat is off a bit, how we get in about the health debt issues and how we look at long-term workforce sustainability, because we don't know if we're going to need to keep vaccinating people against COVID. that's one of the big unknowns at the moment.
Exactly.
So,
yes. Yeah. The system. Yeah. But meanwhile, well done everybody in getting this set up. It's very impressive.
Yeah, I think that's something that we need to put on our things to come back to list.
Sure.
Future. Yeah. But good points. Thank you, Alison, Murray, and then Howard, please.
Hi. Yes. Thank you. I had a query Kim raised as well about the HPV vaccines in schools and what's happening there with the schools all shut. The other one thing was about carers, unpaid carers. I noticed, for example, on page 125, they fall into category 6, but they're not listed in the, they're not stated in the cohort. What's happening in terms of communicating with unpaid carers? There's a lot of concern out there about what's going to happen, how are they going to get their appointments, not least because we know that they're not registered anywhere, so we don't know who a lot of them are.
Thanks, Alison. Will I pick that one up? Just to say that we're working with the newly commissioned carer support service, who we'll use to help get messages out to those carers who are registered with that service and who are working with that service. We'll also use our care managers who are working with people that they know have carers, and they will help us get the message out as well. There'll also be some public communications as well, but because we're very aware that there are a vast number of unpaid carers who are not necessarily known to us, who don't necessarily come forward and use any of the services that are available for them. So you know, we need to make sure that there are key messages out into the community as well so that people understand you know, when they're eligible to come forward for their vaccination and where they go.
Thank you. Yes, I think there's a lot of concern because people just haven't heard anything yet and know they're not registered and don't know how they're going to be contacted. Just as a little sort of request in terms of TECA, could we have a walkthrough, like a video walkthrough, and also a visual guide of how you take your route to get a vaccine at TECA, because that would help quite a lot of people in going there just to know what to anticipate, particularly. So a lot of our carers that we have in touch with also have some difficulties themselves, particularly things like autism, and to be going into a strange environment is quite difficult. So having a bit of visual guides of what to expect when you get to TECA would be very helpful.
Sandy, do you want to come in on that? I think that's an excellent suggestion.
Yeah, I think the short answer from me is that's a very, very good suggestion. I will take that back this afternoon, just so you understand. We meet daily with Grampian colleagues. That includes senior communications team. I will put that suggestion and request to them today. So it's a really good suggestion. Thank you.
Thank you. Thank you very much.
Howard, and then Alan Gray.
Hi, thanks. One thing that's likely to influence where people want to go is lengths of queues. I mean, my family are all in Glasgow, and I had a text the other day there where people were having to wait an hour at the big centre in Glasgow. And I think if it was anything like that length of time, I think people would not be keen on going to TECA. So I think we have to be mindful of that. I know we haven't started, so we don't know how it will be. But I think at this time of the year, I mean, for example, if I go out there, I'll be in a wheelchair, and sitting for an hour in the northeast at this time of the year is not to be seen as where someplace locally would be much more attractive. So I think we have just to be mindful of that.
Okay. Yep. Sandy, do you want to come in on that?
Yeah, again, a very well-informed point based on people's judgment. Just to give one part of assurance at P&G Live, if you imagine, people won't be queuing outside, they'll be queuing inside. And the best way I could describe it would be, if you've ever been to Disneyland or Paris Disney, where you kind of go inside and sort of zigzag and barriers, you'd be queuing in the main hall where the kind of events are. So basically the front door, you'll get past security, come in, and nobody will be queuing outside. That definitely won't happen. And just when I'm mentioning it, I guess I should maybe mention, you got me thinking, we should also highlight that some of the underground car parking will be available for disabled people to come in, and they'll have the option, sensitively, one of the P&J people will sensitively say, are you okay to go kind of up the escalator to where you're going, or do you want us to get on a walkie-talkie and get a vaccinator to come down? So then an option would be to basically, you just need to get outside your car if you were in a wheelchair or not able to kind of travel far, but you wouldn't be outside, I guess, although the car park's obviously an element of outside, but we wouldn't expect people to have to go up the stairs, up the lift, the escalator if they didn't need to or were unable to.
Okay, thanks, Andy. I suppose that the previous point about a video walkthrough would obviously highlight that. Thanks.
Okay. Alan, and then Jenny Gibb.
Thanks, more than a couple of quick comments. Sarah, really just saying, to reflect back on the flu vaccinations, to have achieved the scale up in an ordinary year would have been fantastic. To have achieved what we did in the current circumstances, I think is an exceptional testament to our staff and also to the excellent public response. And I think the other thing I just want to acknowledge and say thanks is really just for the fantastic support we've had around from partners around establishing the system for the mass vaccination programme. Again, that's been exceptional. I think, it's something that we've been fortunate to have in the city, and yet again, it's come to the front in terms of helping us move very, very quickly to establish, a centre of the scale of the P&J Alive, and also other supporting arrangements. I just want to say thanks to all the partners, some of who are on the call, some who are not. I think the response has been exceptional and seamless, and I think, I hope it's something we can hold on to again for the longer term. But I just want to say thanks on a personal basis for the help and support that David and myself and other colleagues have had in getting us to this stage. We've still got further work to do, but I think the support we've had has been fantastic, and I just say thanks for that.
No, that's really good to hear. I mean, we pride ourselves on our solid working relationships and everybody just getting stuck in, and this is obviously another example of that. So thank you. Jenny.
Thank you. Yes, I just wanted to add that there has been some national agreement. This is to increase our workforce to be able to deliver the vaccination. So there's just in the past week, there's been national agreement that actually we can move to start training and supporting our unregistered workforce to be able to help to deliver. So, that will be part of our plan just in the immediate future. And the other thing I'd probably like to add is also just to say, in terms of the clinics at the moment, I would agree the amount of work that's gone into them has been absolutely phenomenal. But also just to say that the general feedback that we're getting from staff around these clinics are that there's a real feel-good factor about it. People really actually, so I'm thinking about people queuing for a long time, actually going in and getting this vaccination. People are coming out and they feel like there's been a change. So, I think it's important just to keep hold of that.
Yeah, yes, well said. Thank you. I think, John, I still see your hand up. You've got another point to make. John Tomlinson? No.
Apologies.
And Alan's hand's still up as well. I get very confused. Yeah. Okay. I just have one final question. Is there a need for volunteers? So there's been some national publicity about the need for volunteers and possibly working through the Red Cross. What's the position in Grampian? Sandy?
Thank you, Chair. I think the short answer in Aberdeen is we're getting lots of people offering, which is fantastic. But we're encouraging them to go back to either Red Cross, who have a kind of due process, and or ACVO, who have a volunteer centre. We just have to strike the balance between, it might be that I'm wanting to volunteer, but somebody needs to check and make sure that that's okay. So we're basically putting it back to the experts, the Red Cross, and I think it's highly likely as this continues and steps up, and more, as you suggested, maybe even repeats all again and start again back in kind of autumn. I think volunteers, we're getting a few of those and we're pointing them back to the experts in volunteering, which is as I described.
Okay, thank you for that. Mike?
Yeah, I suppose just a quick couple of points. Number one, the feedback we have had for the clinics that exist so far, has been extremely positive, as Jenny said, not just on how it is that Manfield fought better just because they're getting it done, but in actually how they're run. So there hasn't been masses of queuing, etc. The bits that have been worked out beforehand seem to have worked really well. I came for the fact that the amount of work that the likes of Sandy and that is put into working out how to do this safely and efficiently is phenomenal. So we are lucky in that respect. That's a positive for you for a change. For me, Sandy. So there is a lot of positives. We need to be realistic because Sandy is right in that as this ramps up, there will be changes. We have got challenges in getting the right workforce in there and about, and some of this is going to be governed more than anything else by the supply of vaccine. And there has got to be a realistic view on that. We are dependent on that.
Yeah. Thank you, Mike. Alan, your hand's up. You've got something else you want to come in on?
Oh, so apologies, Sarah, that's an old hand, so I'll put it down. Sorry, Paul.
Sorry, that's fine. I just don't want to miss anybody. So I don't see any other offers of contributions. I think we've had a thorough going over of this. So thank you to everybody, and thank you to all the officers who've been very, very helpful with their responses. And I'll contact David afterwards to thank him officially for coming and speaking to us as well. So we've got a recommendation just to note the updates on page 127. I think we need to add a second one, which is for a report to be given to the next meeting of the Clinical and Care Governance Committee, or a meeting as agreed with the chair of that committee, if that's all right with you, Leslie, on childhood vaccinations, including HPV vaccinations. So we'll add that recommendation in as well. Leslie.
That's fine, Sarah. That's great.
Okay, I'll leave it with you to work out with Joe and Sandra and Caroline when is the most appropriate time for that report to come. All right. Okay, thank you very much. Thank you again, Sandy, for your contributions today. I am very reassured that everything's on track. Right, we're on to item 10 now, which is the Bonacore Care Annual Report. And I think we have Gail Woodcock, the Interim Managing Director, here. So, Gail, would you like to say a few words to introduce the annual report? And welcome. It's nice to see you in a different guise.
Thank you very much, Chair. Yeah, so you have in front of you, Alison's kindly prepared the report, a report that brings forward the annual report from 2019 to 2020 for Bonacore Care. So you've obviously all seen that, so I won't go into any detail, but happy to take any questions.
Okay. Actually, while we have you, Gail, you missed our earlier conversation about Bonacore Care and the Granite Care Consortium, and we were going to put an update around members. We just wanted some clarification on what Bonacore Care's original role was, and assurance that there was no impact on frontline service delivery with Bonacore Care coming out. Sorry to bring this on you. Sorry about that. So you can tell me that you're happy. I'd be happy with a written update if that's easy, if that's preferable. But if you were able to give us some clarity on it just now, that'd be great.
Yeah, happy to do that, Chair. So Bonacore Care were one of the 10 original partners that got together to form the consortium, and during that process of development we were obviously a very active partner in that. However, it did become clear that in terms of the rates that we provide in terms of our staff, that we couldn't actually be part of the delivery of the contract, because we couldn't do that within the while meeting the staff terms and conditions that we currently uphold within Bonacore Care. So we still keep in contact with the consortium, and we're really keen, for example, to deliver training on the enablement approach that has been adopted within Bonacore Care. I know the consortium's keen to adopt a similar approach, so we continue to have discussions, albeit we're not a formal partner in the consortium.
Okay, that's great, thank you. John Cook, it was you who raised this issue originally. Are you satisfied with that?
Sorry,
I caught you. I knew you were doing something behind the blank screen.
It's all right.
We'll
It's not
do it.
gin. It's only water. Yeah. Yeah. I think so. So it was never going to be the case that Bonacore Care was at the coalface, as it were, when you were in the consortium. Or am I understanding that correctly?
Yeah, so in terms of the rates and the financials that are available, it wouldn't be, you know, basically if we were providing services under that contract, it would cost more money to, you know, Bonacore Care more money, so it wouldn't make financial sense to do that. But we were part of this sort of development and supporting the organisation to form, for example, and we still do keep in regular contact with them.
Okay, right.
Okay, right, thank you. Mike Adams.
Yeah, just a comment. Extremely commendable. That is the reason that Bonacore Care couldn't go forward, and raises slight anxieties for the future on the level of terms and conditions within other parties. Just a thought.
Well, I'm hoping that that's something that Derek Feely's report on adult social care will make some recommendations on. So that's an issue way above our pay grade, Mike. Right, getting back to thank you for that, Gail. So sorry to spring that on you. Back to the annual report. Do we have any comments or questions? Luann.
Thanks. Hi, Gail, and thanks for the report. Really positive annual report. It feels, you know, it was obviously written before COVID and before everything we've gone through. I'm interested in just to get a sense of workforce and how much of a challenge attracting and having a stable workforce is for Bonacore Care, and are you looking at opportunities with the likes of Nestcall to develop new roles? I'm just thinking of the discussions that are happening elsewhere within health, for example, around sort of skilling up the workforce, and so just to get a sense of, you know, does Bonacore Care have a very stable workforce, or is that a challenge as we hear from that sector? And is there discussions, work developing to look at developing new roles locally? I suppose that's my questions. Thanks.
Yes, I suppose staff turnover is one of our key performance indicators. We're keen to make sure that we are an attractive place for people to want to work in. I think obviously this year has been exceptional in terms of COVID, and it's presented a significant amount of challenges to the Bonacore Care workforce, as I know that you're all aware. In recognition of that, one of the key pieces of work that we're focusing on is how do we support our workforce to continue to provide a really good quality of service. So we're looking at the culture, so reviewing what the culture is and how do we support the staff to develop the culture they want to have in place, and to make sure that they have the supports to have that right culture, to enable them to really feel that they can make a positive difference, which of course they do, and really feel valued as part of that organisation. So we're taking a bottom-up approach in terms of listening to the staff, in terms of what's important for them going forward, recognising the challenges that everybody has been under so much over the last year.
Thanks, Gail. It sounds a sensible approach. Thank you.
Okay, I don't have any other hands, so we thank you for coming, Gail. It's an impressive annual report, and next year's one will be very interesting because that'll be mostly COVID, I would imagine. But we've just been asked to note it. I think my recommendations up. Yes, we're being asked to note it, so we'll do that. So thank you, Gail. Thank you. Right. Item 11. The finance update. Alex, over to you.
Thank you, Chair. Firstly, apologies for this being a late report. We've been trying to get this to you because it's suited the meeting dates, and we've been working hard to make the deadline. We've also taken this report to the Risk Audit Performance Committee yesterday, where it was discussed. But just to give you a kind of an overview of where we are in relation to this, the position is largely stable and in line with what we've been reporting throughout the year. There have been some movements up and down, particularly in the social care side our budget, and we're undertaking a more in-depth review into the spend within there. The mainstream position, as in like once we'd removed most of all the COVID stuff out of there, it looks okay, and it's largely in line with what we would have expected. We have received more funding from the Scottish Government since the last time we met in October, and these are highlighted in grey in the table in 3.2, the values that have been received, and I'm expecting a further announcement over the next few days of more funding to cover the amounts that are included within the mobilisation plan. As we've discussed throughout the year, should a gap start to materialise and that funding not being forthcoming, then we can certainly call an urgent meeting at short notice to deal with any items that arise as a result of that. Looking forward to next year, we've had some significant movements in social care, and what we need to now do is to get to the bottom of what this means for next year budget, and whether this is likely to be a new trend and a new spend on social care, and so we'll see potentially less spend on residential care, but more spend on care at home. So that's something that we need to get to the bottom of, and within for next year as well, we have to have a look at the savings that we haven't been able to deliver, which are being funded by the Scottish Government this year, because they'll potentially become a pressure next financial year. We have delivered £3.3 million of the savings that we initially set out at the start of the financial year to deliver, and some of these are on other areas than what the saving was actually initially intended for. So some of the stuff that we've done about localities, we have saved that money, but we probably saved it through short-term vacancies rather than through the sort of redesign that we were considering at this point last year. So what we now need to do is to have a look through that and just see how sustainable that is, and bring that all back into the medium-term financial framework for you at the end of March. We should be we're expecting to get more information on the financial settlement for next financial year on Thursday.
Okay, thank you for that. Comments and questions, anybody? John Tomlinson.
Yes, just I can give a little bit of feedback from the committee yesterday. Alex has kind of highlighted that, but can confirm that the committee were assured around the stability that is apparent within the report and the appendices that we received, along with the clarity about where things might still move, but the actions that are being taken to mitigate and address that, and recognising Alex's approach to not include funds that haven't been received, although we have a strong expectation of that. So we have transparency in the figures. That we're also mindful that because of the substantial movements in some aspects, that will potentially have a knock-on effect to care that is provided, and we touched earlier about health debt, etc. But the primary purpose of this report about financial control, the committee were strongly assured around that in the circumstances, and acknowledging the work that Alex has done along with his team and partners around that. Thanks.
Thank you for that, John. It's good to hear that your committee was assured on this report. Luann.
Thanks. Yeah, and I think on this current year, it's a very helpful and assuring report. I suppose I'm just reflecting on the discussions we've had in this meeting, and what we think. When we started COVID, when it all began, we thought it would be a few months, or certainly we were thinking about it being within this year. Clearly, COVID's not going anywhere fast, and there's going to be ongoing costs. And I suppose I'm thinking about, we know that there will be a mental health impact in our communities. There's the health debt more widely, and there's COVID recovery for people that have had COVID. So I just wondered to get a sense of, are those conversations happening with Scottish Government right now about next year, and you know, that actually there will be significant additional demands on our health and social care services next year.
Alex, yep.
So some of the items that you've mentioned there, Mr. Gray might have a little bit more information than myself on, but certainly from my side of things, that there does seem to be a recognition, for instance, that we will need to support social care providers into the new year and new financial year, and there will be additional costs in relation to PPE and so on that needs to come back. We're really waiting to see what happens on Thursday before I can give you any more information on that, but that's certainly something that we've been working on the premise as a national group. Again, I think what you're kind of highlighting there is really interesting, because the social care supplier sustainability scheme has changed numerous times over the last year as the conditions dictated of COVID, and therefore the amount of funding that was required to be put out to these providers has moved accordingly. So we just need to be mindful of that. But yeah, certainly things like PPE aren't going to go away. But as I say, maybe Mr. Gray's got a little bit more information about some of the aspects around health debt and mental health.
Yeah, I think in terms of continue to respond to COVID and also in recovery, I think there's acknowledgement that that further expenditure will be incurred next year, and I think provision, when you see the budget on Thursday, has been made to allow for that. The details of how much we will get will also be dependent on the wider UK government what it's spent next year. But I think the assurance we've had is that it's likely that that the funding might not be at the same scale, but it should be adequate and sufficient to cover what we require next year. Clearly, there's a lot of uncertainty about how long the COVID situation response continues and what we require. But I think the funding for that, I think my expectation would be that will continue. I think the other thing that'd be interesting in the budget announcement tomorrow is regarding the further investments in primary community care and other Ijb. Certainly had the announcement around sort of support to reduce drug deaths.
You've broken up.
And I think that's something that we should give early consideration to. Oh, sorry.
Could you just repeat that last bit? You broke up a bit. Sorry.
My camera off. Can you hear me now?
Yes, we can. Yes.
Yeah. Sorry. I'll wing back.
No, you've gone, I'm afraid. We'll try and come back to you in a second.
I think Alan was maybe just saying something that we should get more information on Thursday, but I think the bit about there has been additional funding that's been announced recently in relation to drug deaths, and I suppose there may be more of that, but we just have to wait and see how that plays out. But that came, I think, at the end of last week.
All right, John Tomlinson, your hand's still up. Do you want to come back in?
No, sorry, no.
Okay, and I saw John Cook's hand a minute ago, I think. Are you all right, John?
Yeah, sorry, Chair. It was I accidentally hit the raise hand thing by mistake.
Okay, that's fine. Okay, I just wanted to get some assurance that at the moment, I'm speaking with my councillor hat on here as opposed to chair of the Ijb, I suppose. But we're about to go into the council budget process, and at the moment we're not anticipating having to go back to partners for additional funding because we're expecting the shortfall for this year to be covered by the Scottish Government. Is that right, Alex?
Yeah, I think, I mean, at the moment we've got a shortfall of 3.5 million around about there, and as I say, I'm reasonably confident that will come in, and if it doesn't, we'll call the urgent meeting. We've also got our reserves, which we don't want to use for this, and that's very much last resort, but that could provide partners with some degree of protection given how late we are in the financial year. But I also think there'll be more money coming in as well, and that's one of the things I would say in terms of our forecast and forecast position as it sits at the moment. I think there could be more funding that might help out. And also, I think that we also might see some movements on social care, which is the area that I'm most interested in. But certainly, I wouldn't be surprised to see more income coming in. I think it's just mindful just to highlight that to to the board, because we don't know what the conditions associated with that income will be, but it could impact on our bottom line in a positive way.
Okay, that's assuring too. Thank you. I don't see any other hands on this one. I think so. Our normal budget kind of preparation process is that we have a workshop to review what's happened this year in our sort of starting position, and then have a discussion on our revised medium-term financial strategy, which is then formally presented to us in the meeting at the end of March. Is that still the intention this year, Alex? I'm very conscious of all the other work pressures on.
Yeah, I'll be hoping to bring something, at least to do a workshop with the IJB so they can see where the pressure's coming from. But I think, things are moving very quickly, and on Thursday I should get an idea of where we go from there. I can check that back against the medium-term financial strategy that we've got, and then see where we go from there. So I think at some point in February it would be wise that we got together just to talk through some of the solutions. And I guess the 23rd of March is probably slightly later than what we would normally agree our budget, but is after when the partners will hopefully have agreed their budgets, and then that'll be able to feed into our decision on the 23rd of March. So definitely looking at a workshop, but at the moment just waiting to get Thursday's information first.
Okay, so we're looking towards the end of February probably for the workshop. Okay.
Probably, yeah.
Yeah, that's fine. Great. John Cook.
Thanks, Chair. Yeah, just to kind of follow up to that, are we legally able to set what you might term a provisional budget? Because one thing, in terms of some of the discussions we've been already having, we might have additional PPE costs next year. We'll almost certainly have additional PPE costs. We still don't know, but it's quite likely that a COVID vaccination program might be an annual event. So there's kind of it strikes me that there are probably some things that we can anticipate happening, but then there are the new normal might be a very, very different place. So it just seems a bit difficult at the moment to be able to set a budget with any degree of certainty. So I just wondered what
Well, we were in this position last year too with COVID, and and they're moving. It's vital that we have a medium-term financial strategy because we need a sound financial framework. But I think I see Angela's hand, so I'll take Angela.
Yeah, just to respond to Councillor Cook's point, I guess both governments are proceeding to set public finance budgets. So notwithstanding the level of uncertainty, both governments are indicating that they want public service to move, but absolutely accept the point that you're making, Councillor Cook. There will be ongoing uncertainty, and I guess the financial planning assumptions are mirroring the assumptions that we're making that at some point the pandemic is going to de-escalate and move to an epidemic. But of course, at any point it could come back up to a pandemic. So I guess there's a challenge for our collective CFOs to just keep refining the financial planning assumptions to mirror what the nature of the pandemic. I certainly can see that in terms of approving a budget, that subsequently thereafter, Councillor Cook, we may have to revise budgets, and I guess our CFOs would bring that forward in terms of proposals for environments or further adjustment on your funding. But we're clear we will need to absolutely keep an audit trail around all of the assumptions that we're making. If you go back to kind of regional council days, Councillor Cook, there used to be a discipline of revised budgets, so councils at that point would set initial budgets and then could go forward and revise. But absolutely, these are discussions that the finance community are having against the backdrop of the huge uncertainty. But for the very reason that Councillor Duncan said, we do have statutory requirements around our budget process, particularly in terms of the authorisation of fees and charges, which Council will have to do on behalf of the IGB, and we have statutory duties around setting tax and so on. But you're absolutely right, there's a huge amount of uncertainty. So I think the understanding from officers, given the kind of guidance from both governments, is proceed make the best assumptions that you possibly can based on where the pandemic is at this stage. And if we have to revise it, we would come back. But of course, you know, there's our collective CFOs also have to abide by their own professional codes of practice around all of this, so they'll be mindful about you know, you can't stretch the assumptions too far and therefore undermine the credibility of the numbers. But I think that's the basis on which we're going to collectively try and proceed, Councillor Cook.
Thanks. That all makes total complete sense. I'm just glad I'm not a finance officer.
Yeah. Yes, indeed. I'm very glad we have the chief finance officer. We do actually. So, okay, right. So we're asked on the recommendations are on page 112. We're asked to note the report and the environments, which we've done, and we're asked to approve some budget environments in Appendix F. So we're content to do that. Fine, good, thank you. And thank you for your work at very short notice on this, Alex. And we look forward to getting a date for the workshop at the end of February, and then to seeing the revised medium-term financial strategy in March. Right, we've done vaccinations. So we're on item 13, Rosewell House.
Thanks, Sarah. It's Alison. I'll come back in front if that's okay.
Yep.
So this report is in relation to plans that we have put in, and that we're and a new proposal that we've also put in place for Rosewell House. The board will recall that we brought a paper in October last year with regards to changing the Rosewell House registration from Bonacore Care to Aberdeen City Council, which would enable us to move forward with a more integrated approach to the care that is provided on those premises. This latest proposal that we put in place doesn't change that in any way. We are still progressing that, and that is ultimately our long-term goal. But just with the increase in pressure and demand, particularly on ARI, and us requiring to assist with that in terms of creating more capacity for an interim period of 16 weeks. We are proposing that part of the Rosewell House premises. Rosewell House has 60 beds in total, so we're proposing that 40 of those beds come under NHS management, and it becomes a sort of split facility, if you like. That enables us to access the beds that are available there and increase flow from hospital. As a care home, Rosewell House has experienced, in line with others, some COVID cases, both in staff and residents, and under the national guidance that we operate to in COVID outbreaks, that makes some beds closed to admissions. And by adopting this new proposal, this enables us to free up these beds and increase that flow from ARI, and indeed make step up care available from the community should that be required as well, but diverting that from hospital. So the proposal was agreed by NHS Grampian Gold Command, and we implemented 10 beds open from the 18th of January. So this proposal, this paper, sorry, is really just keeping the IJB up to date with those latest changes in response to the current situation.
Fine, thank you, Alison. Comments and questions from the board? John Tomlinson and Ren Kim.
Thank you. Yes, can you just clarify on page 21? It talks about Bonacore Care agreeing to this, or agreeing to aspects in principle. Is that just a timing issue for them to formally approve something? Or I've just wondered why it wasn't more certain than just in principle. Well, Gail's here, great.
Gail, yep.
Yeah, through you, Chair, so I can respond to that, John. So the board took a decision to agree to it. The speed that was required in the various legal documentation means that we have what I would describe as probably not the right legal terminology, but interim legal documentation in place to allow the change to happen as of the Monday, to allow us time to work through the detailed, more formal service level agreement and licence to occupy agreement. So it's probably not the right legal terminology, but if that gives you a flavour of what we've done over the last week or so.
No, that's fine. I assumed it was that. It was just to clarify that there wasn't any potential hiccup there. Thank you.
Okay, Kim and then Philip.
Yeah, I just wanted to ask that if within the 16-week period or prior to the end of that 16-week period, if there's going to be a full review, because I do wonder with changing to some of the beds to NHS beds, there must be a number of codependencies associated with that, and perhaps it's a better way of working. I don't know. And I just wondered if there's going to be a full review or if it's a definite that at the end of the 16-week period, it will revert to Bonacore and no more NHS beds.
Sandra?
Do you want me to come back in on that? Yeah, definitely. So the period of review, Kim, will be going on during this, I think during the 16 weeks. It will be constantly under review. One of the reasons for putting in the clinical and professional group is to monitor whether there's any unintended consequences, how we're doing that, making sure we've got good governance around the whole process and keep each of the 3 partners abreast of what's happening, also to monitor things. The review will take place. I think I've forgotten your other question there. Was it just the review?
It was just the review. It's just, it sounds from the paper that it doesn't say they'll be reviewed, but it did sound that in 16 weeks it will go to the original plan.
I know what I was going to say. Sorry, there's 2 interdependencies. I think that the reason we chose 16 weeks was 2 interdependencies. One was based on the vaccinations, so mindful that all our care homes have had their first eligible vaccination, but the second vaccination is not there, and also that we're working through our frontline staff. So it's what the impact the vaccination brings on that level of stability within there, and also with regards to surge and flow and the issues that were under Operation Snowdrop. So the decision has been made to enhance both of those issues. So we'll wait and see how that's landing, but we'll keep it constantly under review. So from and your other happy to have you around that if you need to be as well. So that'd be helpful.
But the change of registration with the care inspector, it's continuing.
The registration with the care inspector is a variation of registration, so it's moving from 60 to 20 beds. If we did go back up to 60 beds, that's just a change for a variation from 20 back to 60. But I'll let Gail come in if there's anything she wants to add on that.
Yeah, so just to confirm what Sandra said, so we've put in place a variation to our care inspectorate registration from 60 to 20 beds, and that's going through the process.
I think Kim's point is the decision that was taken to create a kind of intermediate facility with a kind of multidisciplinary integrated team for multi-partners. I think Kim's asking if that decision will be reconsidered in the light of this experience. So the decision that the Ijb took in October, are we going to be asked to revisit that?
Oh, apologies. That's not the intent, is to continue with the integrated intermediate community facility. That's the ambition that we had moved forward with that. And with regards to the registration, with it moving over to ACC, I think that again will be determined on how we progress. Sorry, Angela.
I think it's probably important I think it's important to be very clear with staff what the intention is on this. Because if people are moving to Rosewell but thinking that it might all change, or not moving because they think it won't change, that's a really important consideration. So I think it's important to get on the record today that the decision that the Ijb took in October is still our preferred model for Rosewell in the future. This is just an interim move to help with surge and flow across the system. Angela, do you want to come in?
Yeah, just to underscore, that's the strategic intent remains as Kim, but again, back to the comment I made in response to Councillor Cook's question, this intermediate need that may need to extend again, depending on how the pandemic progresses. But of course, during this interim approach that we're putting in place, we're going to get a lot of learning, again, back to Councillor Cook's earlier point. So it would be right to reflect on lessons learned from this experience and to take that into the permanent strategic intention. So the colleagues will absolutely do the review in terms of clinical assurance around this 16 period. That review that will constantly happen on a daily, if not more frequent basis. But in terms of taking lessons learnt from this 16-week trial for the permanent approach going forward, of course, colleagues will take that on board. But absolutely, just to underscore the point, in terms of the frailty pathway reform, this is a critical part of this, and whilst it brings a lot more challenge to be trying to progress this at this point, the intention is still there, because the demand will continue to grow and going forward. So it is important that whilst we respond to pandemic, we have to continue to drive the reform agenda, and again, that's back to ensuring long-term sustainability. The point that Luann was making earlier on, reform will absolutely need to continue at pace to ensure we are sustainable going forward. So the strategic intention is still there, Kim.
Okay, you happy? Right, we've got Philip and then John Cook.
Thank you, Chair. Just really wanted to explore very briefly how robust what is going to be done, procedures that are going to be carried out for admitting people into Rosewell House for surge capacity. So there's mention in the report of visitors being tested with lateral flow testing, which of course is the less accurate, less efficacious testing technique. It also mentions regular testing of all staff. It doesn't say any more than regular testing of all staff. And I wondered if I could ask if you could perhaps clarify what you actually mean by regular testing of staff, frequency, type of testing, so forth.
Okay, who wants to come in on that? Andrew?
Yep, I'll come in. We'll be following the guidance that's provided by Public Health Scotland and by the IPC guidance that's provided for the beds that will be operating as an NHS facility. We'll get our guidance from the IPC and from the acute addendums to the infection prevention control. So whatever testing is put in place there, we'll have to follow those guidance.
Right, so when you're hoping to actually use Rosewell House for this overflow capacity, if you haven't got guidance yet?
No, the guidance is in place. Sorry, I'm just off the top of my head. I don't want to give you the wrong guidance. I can certainly follow up with it, but I'm not aware to tell you exactly what it is when I'm not 100% sure. We are already started within Rosewell. We'd say that we already have of the capacity already with 15 admissions over since, I've forgotten which day this is, Monday, since, yeah. So we have clients in already. So.
Thank you. So I would appreciate just to get a bit of detail. But the other thing I was going to say was there's no mention in the report of staff being encouraged to be vaccinated against COVID. It's clearly that will be a criteria, won't it? I know you can't make them, you can encourage them. There's no mention of that in the report. So
frontline staff are one of our cohorts for vaccination. Woodend had a peer vaccination site in, and through our vaccinations at the Health Village, we've prioritised care home staff. I think there's a huge percentage of care home staff already being vaccinated. But through as they're applying, we're definitely encouraging that and have been working with our providers right across the services to encourage that, doing ad hoc as well where we can, because when we've been in to do residents vaccination. So definitely encouraging exactly where we can, but no, we cannot force. It's a individual's right to choose whether they have a vaccination or not. Yeah.
Yes, thank you. And I'm sorry, you did actually say at a previous point that the staff were being vaccinated, but it was just strange that there's no words to that effect in the report. Anyway, thank you very much.
Thank you, Philip. John Cook and then Luann.
Thanks. And apologies if this is a duplicate question. I had a sound blip. So the last few minutes, Just to confirm, if I'm reading the paper correct, we've got 13 temporary residents and 1 permanent resident in the care home bit. They'll be unaffected, because I know we discussed this when we had the original discussion back in October. And at that point, we had reassurance that those folk wouldn't be adversely affected. Am I right in thinking that that's still the case with this?
Yes, absolutely. But I'll let Gail come in there in response to that.
Yeah, so just to confirm that we've obviously had conversations with all of the service users and their relatives where appropriate, so they're aware of the change, but from their perspective in terms of the care and the support that they provide through Bonacore Care as that part of the care home, there is no change. So there's no change in terms of where they're located, there's no change in terms of the amount of care and support they are provided as part of that care home element.
Thanks, that's reassuring. And I did have another question on staff, but Sarah's already asked it, so that's fine. Thank you.
Okay. Thank you. Luann.
Thanks, and I really welcome this, and I think it sounds like it's essential for the pressures the system have just now that we have this capacity within Rosewell. In the 40-bedded unit, given it's a 16-week programme, is there a work stream that's specifically gathering patient and carer experience so that we make sure that that really becomes the centre of how we learn lessons from this temporary model, so that we can build in people's actual experiences into what becomes the permanent arrangements?
I would say that have we specifically got staff focused around gathering that? I think we would be gathering just information as we go along. We'd have to use them, for example, complaints and feedback as we're gathering it. It's a really valid point, and I think we are gathering some data, but capacity is running through my head at the moment, thinking that I think our biggest focus on this is actually helping the flow through, and mindful of there. So I'm not. I would need to come back and think about that, Luann, but I am conscious about how we would do that justice in that period of time.
Angela, do you want to come in?
Yeah, just to build on Sandra, of course, because we are where we are with the crisis, rightly, it's important that there's assurance around the practice that's been put in place at this point. But given, Luann, the intention is to run it for 16 weeks, I think we could take your point on board, perhaps for the back end of that 16 weeks, subject to where we are with the pandemic. So I could hear the kind of concern in Sandra's voice. Of course, the team are hugely stretched, as everybody is, but it's a valid point. But perhaps something we can take on board for the end of the 16 week, and then particularly if it is extended, depending on where we're at with the pandemic. But you're absolutely right in terms of informing that long-term strategic intention. It would make sense to do that. But I think here and now there's immediate risk that the teams are collectively concerned with. But Luann, happy, I think, for the team to take that on board for the tail end of the 16 week.
Thanks, that's absolutely reasonable. I think we've got to be, as we've said throughout the meeting, really conscious of the pressures just now, but equally at an appropriate time, our lived experience will give us nuggets of wisdom that we won't get otherwise. So yeah, if it can be built in at an appropriate time, that would be good. Thank you.
Thank you. I don't see any other hands, so I think we'll move to the recommendations. We're on page 143 of the pack. Actually, I think I'm working off a different pack to you all. Sorry about this. I'll just ignore me. So we're asked to endorse the actions taken by the system-wide team to utilise part of Rosewell House as an interim NHS facility. We're noting that it's an interim position for up to 16 weeks, and the permanent arrangements will be progressed by a care home registration or care inspectorate registration as per our previous direction from the October meeting. And we're noting, in line with the recommendations from the October meeting, that assurance and oversight of service delivery at Rosewell House will be monitored by the Clinical and Care Governance Committee. Performance reports will be provided by the newly formed Rosewell Interim Clinical and Professional Oversight Group, and the Grantham Care Home Oversight Group will continue to have a role in support, scrutiny and assurance. We're content with those recommendations. I don't see any dissent, so that's fine. Thank you. Final item today is the NHS Grampian Health and Social Care Winter Plan. Who's already speaking to this at the moment? Alison, yeah?
Yeah. Thanks, Sarah. I can introduce this. I think Alan may also wish to comment on this. But this is the NHS Grampian Winter Surge Plan, which has been prepared with including ourselves as partners. We would normally prepare our own winter plan. However, this year, in keeping with the partnership arrangements that we have been working so well over the COVID period, we worked alongside NHS Grampian to incorporate our winter arrangements into the overall plan. So this plan was approved at the NHS Grampian board meeting on the 14th of January, on the understanding that it would also be brought to the 3 IJBs within the Grampian area for approval as well. It's important to note that it is a live document. It will be updated regularly, so the IJB do still have the opportunity to comment and input into that. So the plan's in front of you there, and I will open it up for any queries unless Alan wants to add anything to that introduction.
I have nothing to add. No, thank you.
Okay, thank you. Thank you. Comments and queries? John Tomlinson.
Yes, thanks. With NHS hat on, had an opportunity to see this, so don't have anything specific to raise, but I do think it's interesting that I mean it demonstrates the high quality of joint working, cross-working across our system here, with the different partners and across the chief officers and their teams. I think what's interesting for us as board members is looking ahead over the next 12-18 months is how we can kind of catch up our governance that kind of joins up around this, of us being asked to approve this. I mean, we don't really have an opportunity to not approve it today, in a sense. And so it's not a complaint, it's just maybe something for us to reflect on in our informal sessions, just what governance looks like now that we've reached this very positive stage of excellent cross-working at the executive level. So it's just a comment, and that's something we can reflect on offline, if you like, and then bring back to these sorts of meetings.
I suppose you could look at it that actually we give governance by considering the individual elements that feed into this plan. So we have looked at Operation Home First, we've looked at the frailty pathway. Actually, the previous item on Rosewell, all of that is part of this winter plan. It's just we've taken them in individual bits, if you like, rather than seeing the whole plan together. So I think when I read this, I thought, oh yeah, we've talked about this. We've had a paper about this. I recognise quite a lot of what was in the plan. It's just we've taken it in pieces, I suppose. And yes, you're quite right, though. We should reflect on whether that needs to be augmented with an overall look at it before the plan's signed off by NHS Grampian as well. But this has been an exceptional year. I'm not quite sure when we would have done it this year, to be fair. Angela.
Yeah, just wanted to add to that, John. It's the complexity of being in civil contingency and those statutory duties that you would expect as executives to entirely be in full delegation mode. And actually, in reality, we're in civil contingency and we're not in full delegation mode. And therefore, collectively across the whole system, what we're trying to bridge is that the complexity of that situation with governance structures, which by definition aren't as agile as you would have executive structures during civil contingency. And I think what you're teasing out is, of course, understandably, government wants assurance on the executive side that all the mobilisation plans are in place, and they want that understandably at pace. And then you've got a time lag for the kind of the domestic governance sitting back. So I'm not sure there's much that we can fix. I think it's right to call it out and note it, but I think it's this complexity of model that we're in between. We don't have full delegation as your collective officers across the entirety of the system, because all governance systems have come back to full blown. So we're all, I think, always for the remainder of this, John, we're always going to have some of this not being quite synchronised. I don't offer this, that's not a solution I'm offering you. It's just a comment on the complexity of the governance that we're sitting in at the moment.
Yeah, and I think even just that exchange is helpful, that we get on the same wavelength as that, and that's probably all that I'm kind of seeking through this, that we're not looking for things or getting anxious that we should be looking for things when we don't actually need to, and I think that's just a reflection, here, but also the considerations at the NHS side, being a partner on that side. So I think the conversations will help us just settle that that's the landscape we're working in, and it's okay. We're bringing in due diligence on it. Thank you.
I think assurance on performance will be incredibly important, because working out how this plan has actually, whether it's achieved its objectives, for considering next year's plan, when we might still have to take into account COVID, is really, really important. So I'd be expecting RAP and clinical and care governance to be looking at some of the performance metrics from this plan this year. Right, I don't see any other hands. So the recommendation is on page, is that we're asked to approve the Grampian Health and Social Care COVID-19 and Winter Surge Plan. And we're asked to note the opportunity to input into the plan. I think we've just had quite an interesting discussion about that. I don't see any dissent. No? Okay, so we'll approve those recommendations. That brings us to the end of the business today. Our next meeting is the 23rd of February at 10 AM, and it'll be an online meeting again. But thank you for your attendance and your contributions today. Thank you.
Thanks. See you at the training later.